Now we're going to get into a discussion about telemedicine, and the title of this discussion is Telemedicine as a Model for Healthcare Service Delivery. Is Africa ready for care at a distance? And the speakers are Conradie, Robotic Surgery, Netcare Waterfall Hospital; Elliot Sack, CEO of eHealth Group; Dr. Phila Mazamisa, Chief Director, Hospital Services in the Gauteng Department of Health; Dr. Anton Prisloo, IT Director, Independent Practitioners Association; and Kunene, Managing Executive, Public Sector at Telkom. It's an open discussion. Please feel free to jump in and ask questions as we go along.
The discussion is telemedicine as a model for healthcare service delivery. Is Africa ready for care at a distance? And I'm going to ask a question about something that I really don't know anything about. The only thing I know about robots is their movement control devices. So I will jump to Elliot Sack and ask him, are robotics behind the hype?
Technology is developing constantly, and we've been able to invest about $100 million into a technology that can provide a secure platform for specialists to see patients in high acuity settings. So in ICUs, trauma, stroke, operating rooms, and these are instances where you need to have a secure and stable internet connectivity. And obviously the issue in the past has been connectivity and low bandwidth, but our devices run on a very low bandwidth. So it could run as low as 300 kilobytes per second. And our company in the States was involved in the prototype of the Da Vinci robot and sold that technology. And now we've moved into more remote presence telemedicine. And I think it's important for us to, provide healthcare in the rural areas and also expand and leverage off of our rarest assets, which are specialists, which there's a lack of. And we need to maximize our human resources. And I think technology can provide that platform.
Dr. Marius, just in terms of, robotics and the cost and the adoption thereof, what are your views?
The initial outlay of the capital is quite significant. We have to take that leap. We're falling behind in the discrepancy between what the world standard is and what we can offer in South Africa and in Africa. And we have to take that step to keep up. A couple of years ago, we couldn't provide any minimally invasive surgery, and now we're on par. As scientists, the doctors can only see what is necessary, and we can bring the technology to South Africa and make it possible. But we need really the medical insurers to buy into this whole system, and they must trust the clinicians that this is going to be the best way forward. At the moment, the robot, it's fairly new. It's 22 million rand for the Da Vinci robot. The good news is there's other companies that's developing their own robots. So I think this price will come down over a period of time. If you go back a couple of years ago, the first laptops was astronomically expensive, and now you can buy a very decent, good laptop for a fraction of that price. I think most importantly is the medical insurer that we feel must understand, like the clinician, this is the way forward. The robot is going to stay. There's no treatment option that can compete with the robot, and we have to make it work. The clinician will provide the service, but the medical insurer must see the advantage as well for the patient benefit at the end of the day.
Elliot, you spoke about connectivity, and you also spoke about other options that are not bandwidth intensive. What are those? What are those options?
As far as which other specialties can our technology be utilized in?
No, you were speaking about, so we were discussing the robotics and the fact that they are bandwidth intensive. So from a connectivity perspective,
Sure.
You said that there are other options that are not as bandwidth intensive.
Sure.
What are those options?
A lot of telemedicine carts and contraptions that they use on the market don't have a success rate of, they're 50%. They're not reliable enough. So what our company has developed over the years, they've invested about a large amount of capital to invest in a system that can run on a low bandwidth through the cloud. So there's been discussions about the cloud earlier. From your iPad or from your iPhone or from your device, you could log in through our system, which is safe, and then you could see a patient on a very low bandwidth. So this is relevant in Africa because of the lack of bandwidth. So, for even in a rural hospital, so a device can be stationed in a rural hospital in Polokwane, and a specialist is sitting in Durban, and he can be seeing that patient on a very secure line and doing a high acuity assessment, whether the patient's having a stroke, a gunshot wound, or whatever the incidents may be. You're providing that patient with care that he wouldn't be able to receive in these rural hospitals because there's a lack of specialists in rural hospitals, because most specialists cluster into metropolitan areas. Mm-hmm. So the challenge has always been, getting healthcare into the rural areas, but also leveraging off of your specialist reach into metropolitan areas. So a hospital group can have devices stationed at their various hospitals in their geographies and provide access to specialist care, 24/7 care in all of their hospitals, not just the Sandton Hospital or the Pretoria Hospital or the Cape Town Hospital.
Naturally, we've just almost gotten to my next question.
Sure.
So from a mobile solution perspective, in terms of disease management, what are your thoughts, and what are the trends at the moment, and how has the adoption been?
Are you talking about highly infectious diseases or just...
Just across the whole healthcare sector.
You know, and I'm coming from the foot soldiers, the general practitioners, that it's the other end of the spectrum. And if one look at the non-communicable diseases and the infectious diseases that they actually have to coordinate, the doctors in the medical sector hasn't really taken the move into adopting IT. I mean, there's wonderful systems going out, and if you can have someone putting information in there and share that information with the doctor, it's very valuable. I think the problem that we have is that a lot of the systems that's developed was developed more maybe with the business objectives of the companies that's developing it, and not really looking at the end user and the interface. And that's why we see that, especially say in electronic health records, the adoption is so low, because it's very cumbersome for the user to use. He's not used to it. I think, frankly, the doctor just don't see the value in his daily practice of moving over from a thing that he's been using for 20 years that he thought was fine. It's very important that when one develop things and you want to introduce a system to any group of doctors, that one really go and look in the practice, that it fits into the workflow, and that the doctor understands the value that it's having for him. Maybe it goes for the nurses also that needs to use it, and then also take it in a step-by-step approach, and don't bombard them with a whole screen that's so busy. When he puts it on, he just switches it off and just revert back to paper. So mobile health can definitely play a big role. I think the thing that we need to start focus is how we're going to get the medical practitioners engaging and start using these tools that was developed.
So in your view, what could actually be changed in the current sort of systems to enable doctors to actually adopt it?
I think if we look in the South African environment, starting in the private sector, we've got 80 or 90 odd medical schemes, 20 administrators. So and all those companies are building great infra and IT infrastructure and having a lot of information that needs to be presented to a doctor. Where we lose the doctor is that each of these companies are building their own websites, their own apps, their own portals. So the doctor sits there with all this, say, on one iPad. The way that we at the IPA Foundation went was to say, but let's give the doctor a unified experience. So we give him one front end that he's familiar with, and then let there rather be integration in the back end. So to answer the question is, make it simple for the user and uncomplicated. And then all the other resources or the other information that you want him to see have integrations in the back end. Let him move around between databases easily. If you think about how easy, when we go on the internet and we want to sign up in a new portal, we use our Google credentials to move from one portal to another. Yeah. I mean, the doctor has a username and password here, a username and password there. Yeah. We've never adopted it. So get a unified, a single sign-on that doctors can use. And then lastly is... and put it in the workflow. I mean, a lot of these stuff, the majority of apps and things that's available, the doctor needs to register the patient. The doctor needs to go and enter the website. But he's never done it. I mean, the secretary was doing those kind of things for it. So if you don't put it in the workflow where the secretary still does her work and then pass it on to the doctor to do his work, it is going to be an uphill battle to get him to buy in.
Thank you for those insights. Now we move on to this whole conversation on telemedicine. Dr. Mazamisa, the diagnosis and the treatment via telemedicine, how safe is that? And I mean, just giving you an example, a lot of the people that I know today use Google as a self-diagnosis tool. So I've got a headache, I go into my Google and I Google, this is the headache, it's been going on for 5 hours, and then we think we can actually do that. So from a medical perspective, how safe is the whole diagnosis and treatment side done?
Well, with telemedicine, we assume that it would be medical practitioners. The example that you're giving, I'm actually smiling because I'd forgotten about it. But that's not what we're talking about. We're talking about a medical practitioner or clinical practitioners at both ends.
Okay.
They know what they are talking about. And the solution is user-friendly. I'm glad he has mentioned that, so that people take up to it. And the diagnosis is accurate. So the patient is brought in this because the patient is there. There's a doctor in that or a nurse practitioner, and they are consulting another clinician on the other end. They are talking high-end medicine, but the government will take care of both low-end and high-end. Low-end in terms of level of needs of the patient. So we're looking at solutions that would cover our primary health care setting so that the doctor who is at the primary health care setting has got access, instead of shunting the patient up and down, has got telemedicine access to a specialist. If we can make an example, for instance, if they are in Soweto, then they have access to Charlotte Maxeke, for instance, Johannesburg Hospital, and quickly, real time, the consultant on that side is able to advise, is able to say, no, that patient must come in, is able to say, no, this one, you can do this. One, they would cut the time in terms of travel. Patient has got access to a higher level of care, which normally, it would have maybe taken an appointment day. We can use it in many, many ways. The safety to me and the reliability are very important. Somebody mentioned the issue of electricity here. Once you have this type of solutions, they have to work most of the time, if not all the time, because people get dependent on them. And I don't think, once you've used them, I don't think you can go back. Maybe I will get a chance and talk about the uptake, because it's not very good, especially in us in the urban areas, though I think we can benefit a lot from it.
I see the picture that you're painting. And then if we then look at the difference between the public healthcare systems and the private healthcare systems, would you be able to give me a view in terms of one, adoption and uptake, and how effective is it?
I'll talk on behalf of public. I've worked in private before, but I'm not qualified to talk on their behalf now. But in public, we see high volumes of patients. We use lots of inter-facility transport. So we see this as an advantage. But besides, those are patient advantages on the side of the patient. Junior doctors working in the outer lying hospitals are also at an advantage in that they would get training all the time and affirmation of by the way, medicine has got an element of apprenticeship. You have to see so many of that condition, and then you end up getting the confidence, and then you can diagnose. So we hope at the end of it all, it would assist us in many areas. Good for the patient, good for the training of doctors. Those are the main things. And cut out the inter-facility transportation.
Who's picking up on the private side?
Going back to adoption, from me, we think that the general practitioners, because that's where I'm familiar, as the coordinator of care, luckily they've gone through the apprenticeships. What we have found is because they were taught in an hospital environment, they're basically now placed in the private sector in a practice environment that's totally different than the hospital environment. They don't have the resources with them. I mean, they can't do anything because they don't have the machines and so on. So there's definitely a drive in the private sector to start reskilling the general practitioners, also because of the shortage of specialists in the rural areas, getting general practitioners to go back into hospitals to start doing procedures again. And I think this is where telemedicine can play a big role to help them with that education.
And in your experience, the change management side of things, I think the change management also talks to adoption, and we talk about the doctors getting challenged with the workflow in that instance. And I totally understand. I mean, when I go to the doctor, there's a card. The lady at the reception sorts out everything. By the time I walk in, he's just got my card and he takes it there. So do you think that from a provider perspective, there's been an oversight in terms of understanding the real work of the doctors?
The angle that the funders are coming from, it's a business approach, and they need to manage their patients better, and they come up with rules and protocols. And the problem is that the doctor in the field don't have the capacity to adhere to all these rules. So what happens is after a while he just gets some kind of way of doing it, and he will sign a contract with a funder or with a scheme and go on the way that he was used to do it. I mean, we've started to roll out an electronic platform with doctors last month, And one of the things that I'm currently doing is I'm visiting practices to see if I can understand what is really the value for the doctor, because we had also a perceived value, but when you walk into that practice, then you actually realize, but the value that we thought it will have for the doctor is really not there. So I don't have the answer yet, and maybe if you ask me in 6 months' time, I will know better. But what I do know is that we need to spend a lot of work there in the practices where we want to implement these things. That one surely know that the doctors are seeing value in what we're developing. Change management is going to be the greatest thing, especially at the low end. And there again, I mean, there's a place for specialist medicines and what we've been discussing with the telemedicine. But in the primary care setting, change, it's difficult if you don't show the value to the doctor.
I think we have a question at the back. Somebody can...
I apologise because I had to step up, but I think there's one massive stakeholder we've got to take on board with this, and that is our own HPCSA. Because at the moment they're against telemedicine. And I do feel that somewhere in this process that we need to get them on board to be able to allow this to be able to happen both in the public and the private sector.
I'm Dr. Maggie Mujapelo from Mediwell. I happen to represent the healthcare at the primary care level. I've been in practice for the past 30 years. I've turned a health technopreneur because I've realized the value of utilizing digital healthcare. I agree with the statement of saying that the uptake on the ground in terms of adoption of technology for the healthcare providers is very, very low. And I think it will remain low as long as the primary doctors, the doctors on the ground, are not included in the continuum or in decision making, so that in a platform like this where they can understand how valuable their role is, to understand the benefits and the trend that is happening in the country. I also happen to be in the board of one of the medical aids. All the technological advances, millions of money that we have spent to network with our designated providers, the uptake has been less than 10%. So the money that we have spent is not realizing value, and I have said that we should also not forget that we should influence policy in our medical schools. At the moment, we don't have anything at medical school. So if you've got a doctor who has just qualified and you tell them about the technology that is going to change life, I mean, we use proactive health intervention to manage and intervene in the big five, you know, the lifestyle diseases. And we have formed a network of the health tech-savvy doctors that we train, we make sure that we attend this platform so that we can mitigate this fragmented healthcare. And I believe that as long as the doctor, you know, is at the primary care level, where majority of our people are in terms of care, is not understanding, is not involved in the continuum, which is the case in most platforms, it's going to be a challenge.
One of the statements that Dr. Mujapelo makes is the fact that there isn't maybe a coordinated thrust towards achieving all of that. And excuse me for my ignorance. So is there an e-healthcare charter, or is there a white paper on e-healthcare with norms and standards and all of that stuff?
The Minister of Health just recently mandated that there needs to be a committee to inform him about all the e-health and ICT strategies moving forward. So it's not actually been developed yet, but it's in development now. There's a lot of white paper with NHI, with different groups, the HPCSA, the lady mentioned. I wouldn't say they're against it, but they have an old guideline which they need to update. We need to work with policymakers, because you're kind of trying to teach them, and it's a constantly evolving sector, e-medicine, e-healthcare. And we need to work with people to understand that it's constantly growing. We can't run off of a guideline that was written a couple years ago when it's constantly expanding. So I think the minister is taking the initiative to create a committee that's going to advise him from all different provinces, people that have been highly experienced in the ICT sector, to advise him on that.
Dr. Mazamisa, challenges to the uptake of telemedicine, what are they?
Chair, because I'm in Gauteng, I must say, I did mention this a little bit earlier, to say there's an assumption which is not necessarily correct, that telemedicine, I think when it was introduced, it was for rural outlying hospitals, because there's a shortage of doctors there, or shortage of clinicians in general, so they would be supported by a faraway institution, probably an academic institution. But where we are now, we know that that is not the truth. Even though we claim we're an urban province, if you take the distance between, for instance, Chris Anibara and Sebokeng Hospital, it's a good 60 kilometers. And actually, as he's mentioning, the minister, right now, we haven't started, but the principle is there that if you take Dr. George Mkhare, the then Garankwa Hospital, the hospitals that refer to it are quite far. It would be Bretts, which is more on the northwest side. It would be Jubilee, which is another 55 kilometers, and so on, and Odi, which is also another 25 kilometers. So we've come to realize that it would benefit us to have this communication. But importantly, they must work because we will depend on them. The issue of change management is not just with private, it's also with public. You know, the usage of technology has increased by and large, starting from a personal level. People are having cell phones, people are using ATMs, and so on and so forth. So change management would be important, but we think uptake can be, people can be more receptive by now, especially as younger people qualify. But I do want to talk to what she's saying. It is very important. We need to consult virtually everyone and everybody. And consultation doesn't stop when you're introducing it. You know, you have to keep on at it. The doctor who talked to you said, you train and retrain. People come and go. So you have to just keep at it. But the uptake can be improved. I don't know, Elliot, maybe.
I want to just go, elaborate on the topic of making lives easier for the specialists. And if the telemedicine solution provided is reliable and it's stationed in areas, it really makes the life easier for the specialist, because the specialist doesn't have to travel into bad areas like Mitchell's Plain, for instance, in the middle of the night. So they have to constantly ship patients out in the middle of the night. Whereas if you have a device stationed in your hospital, the specialist can see his patient from the comfort of his own home, sitting with his family, watching TV. He could be doing his rounds. I spoke to one top doctor in the country, and he was saying how he has to travel back and forth from a certain hospital 3-4 times a day. Sometimes there's traffic, you got to think the robots are out. Or also a lot of doctors, they work from say 7 to 7. But then when they're at home, there's a lot of legal risk, because when a patient has a complication in the middle of the night, there's not the staff that's there, maybe a nurse can't handle a complicated situation. So then the hospital is at risk for what occurs to that patient while he's not being treated properly for that type of incident. And I think that from a legal reduction perspective, as far as legal risks that the hospital groups and insurers will look at from that alone, the telemedicine solution's worthwhile implementing, let alone also, the benefits that it provides to the specialists for also getting patient referrals. Say you're in an outlying area, you're going to meet patients that you never meet before, and then you get patient referrals for complicated procedures. So a lot of hospital groups in the States will put a device in another hospital, even a competing hospital, because their specialists will get that complicated procedure, and then that's where they make a lot of their money and also build relationships, and they keep a continuous relationships with their patients. And also patients, like she mentioned, don't have to be transported away from their families. So say they're in Pretoria and then they have to come to Joburg, there's an ease for the families to see their family member in hospital easier, and it reduces costs on transportation.
So of course, with all these evolutions in the healthcare space, telemedicine and all of that stuff, there's bound to be some legal implications and jurisdiction, implications. How are those being addressed, and where does liability lie?
The HPCSA has put some guidelines out as far as in the private sector. They allow you to practice telemedicine, but you first need to see a South African GP first, and then he needs to refer you on. So an overseas doctor can see you can get a second opinion from a specialist overseas, but you need to first see a South African GP. So that kind of complicates things. So initially you have to see a GP first, then he needs to refer you to a specialist. So that's currently their guidelines. They obviously understand that they need to bring in overseas doctors to aid with the load, but I mean, you have to go through a South African GP and then get referred. That's how South Africa is currently working on the telemedicine guidelines mandated by the HPCSA.
Maybe just to say that we view this as an augmentation. It doesn't replace the responsibility of a doctor. Mm-hmm. You still have to do your work as a doctor. I'm glad you mentioned the issue of skilling, because you wouldn't be referring virtually. I mean, in a normal practice, you don't refer everyone. Yeah. You have a certain level of competence where you're able to manage the majority of cases that present. However, when you are in that doubt, then you refer. So now here we're getting an augmentation that eases that referral consult. So I'm not quite sure. I haven't looked at this at the legal issues, but I want to think that the doctor would still be taking responsibility for his or her patients.
I'm listening to all these views. The healthcare providers or the industry looks at innovating and evolving and coming up with better ways of dealing with this with service delivery in the healthcare space. And yet I hear these conversations about how it's overwhelming for the doctors, how it's overwhelming for the people that work that are supposed to provide the service. So where do we strike the balance between empowering patients and overwhelming the providers?
It's a good question, because one of the big problems is that in private, that each stakeholder is having their own mandate to perform a certain task and to say look after their patients. In the environment where we are, if we look at the administrators actually compete with each other to get a medical scheme or to administer. What one would have liked to see is the administrators that is administrating the schemes coming together and say, okay, but you know what, don't compete on the front end in the practice with the doctor. And I mean, and a good example is if one look at the practice management systems that the doctors have been using for the last how many years, 20 years, to do billing. Medical administrators left that alone. They didn't see that as a function to go and install practice management systems in practices. All that they are interested is to see that claim that comes in a certain format, the EDI format, and they use that information. So if one can get the administrators to say, okay, but what we just want is certain information in a certain format, and we will take that information in and we will share back information to the user, to the doctor, and don't compete on the front end in the doctor's practice. I think that will be a huge step, but that will need the administrators to come together and say, you know what, let's don't compete. And I think the way to do it is to get a neutral company or a neutral body to drive something like that, so that you can take a lot of the mistrust out of it.
Maybe just to close off before we go into questions. Besides electricity, what is the single most challenge in e-healthcare?
Connectivity and the infrastructure, because I know even rural provinces where the uptake was relatively good, the issue of connectivity, derails the whole process. Yeah. So now maybe the solution providers must come with wireless provisions and all the advanced ways of doing business.
We're going to go into questions.
My name is Taru Simbi. I'm from Healthway Africa. I'm a director of the Healthway Africa. I've heard the doctor here, GP, describing how healthcare providers, they've got different systems that he has to log into. And I don't know in terms of government policy whether there's an appetite to have an information standards committee that dictates what information needs to be collected in what format, such that if your system doesn't meet those standards, it doesn't get accredited and doesn't get on the market.
My name is Yusuf Omoshala. I'm from Nigeria. I'm CIO, Chief Information Officer of Hygia Group. What I've heard today is focused on the South African market. So the question is that, are there plans to roll out in other markets? If the answer is yes, there are clearly a lot of things that has not been properly talked about. So culturally, maybe the South African market is there, but in the rest of Africa, these things have huge cultural implications. Have you scoped it? What are your findings as regards that? Is this something that will be viable? It doesn't look or sound affordable. Also, for many other African nations, you have alternative distribution models. You have alternative models to access this technology that will be maybe some bulk breaking strategy that would allow it to be affordable. You talked about the cloud services. I know there are ways to do all these things.
Technology should provide multiple solutions. So there's obviously different solutions that will meet different budgets of different governments and hospital groups. Companies should look at providing cost-effective and sustainable solutions that governments and private groups can use to build and expand their healthcare systems. Groups should be looking throughout the whole of Africa, not just pick and choose because certain countries are lacking more than others. My goal and my company's goal is to ideally provide innovative telemedicine solutions that would be sustainable for the African continent. Initially, we're obviously going to start in South Africa and move up from there. Obviously, we're not just trying to sell a product. We want to provide a solution. We want to provide education. We want to provide implementation. We want to provide training. We want to provide sustainability. So we want to go into these countries and groups and utilize our resources and manpower to actually create a solution that's actually going to work for the continent, not just come in for a couple years and then go. We want to be here to stay and grow up and provide a solution that makes it easier for the doctors to use and make their lives easier. So I think we need to look at sustainability, training, and obviously transfer of knowledge and education to teach the people moving up. And with the right team of people, we're going to move forward and provide solutions that are going to work for the continent and save lives and make healthcare and improve healthcare better.
Thanks. I will pick up the question that referred to government and the health information systems that we're using. Government is aware that with the whole country, the public sector is using so many solutions, and the decision has been that they won't prescribe which systems should be used. However, what they're going to be hard on is interoperability. That has been the main stand of government. I know right now they are trying to pilot the precursors to electronic health record at primary healthcare level. This is where the pilot work is, and apparently it's doing very well in various provinces. But what they are looking at, it must be able to interface with other systems.
But don't you find that creates a problem on its own, in the sense that if there is no sort of thou shalt do A, B, C, D, E to achieve this outcome, and then you have a fragmented. The reason why we are sitting at the position that we're sitting in now is because there was never a prescription right at the beginning. So we sit now with silos, systems that don't talk to each other, and still the thinking and the standpoint is that you're going to be non-prescriptive. Obviously, 6-7 years down the line, we still find ourselves in that space because, as you know, the for-profit organizations always have their own hooks and things that after a number of years you need to upgrade the software, you need to upgrade that, and it can talk to that. And I hear the issue of interoperability, but my view is that not where we are actually missing the ball?
I think it was a practical approach. When they prescribe, which system should they prescribe? Because as I'm telling you, there's lots of investment all over the country in the various systems, and they are functional to a greater or lesser extent.
Okay.
So it was a well thought issue to say, as long as you can be able to plug that information in this central repository. That's right.
The role that I would see government playing is to create the environment where we can use this technology and where we can use IT to improve health. I mean, and a simple example is the electronic signature. We still can't use the electronic signature that the Communications Act talk about to write the prescription out. So what can happen is that the governing bodies and government can move forward to change legislation. Old legislation that prohibits us from doing certain things, but then also, as I said, making an environment where we can operate. Innovation is always going to lead governments, and the legislative process is always going to be behind. But that's why it's very important just that when they do come out with something, then when the new law comes in, at least look at the existing laws and what's currently happening and enable us to move forward for the next 5 years till it's time to do a next law again.
Yeah, I just want to comment on one of the questions regarding to the robots in the clinical practice and the clinical use. I think what we find is we've got a couple of challenges. First of all, providing the training in South Africa. We provide the training for general practitioners and specialists, but as soon as you want to train on new technology, you always have to exit the country to go and learn new technology. We need to provide the capacity or the facilities where we can train the South African doctors in South Africa. That's one thing. To bring in new technology is actually quite swift. I think the problem lies with the funders in adopting that policies, and maybe we can expedite that process. If we evaluate the process that's delaying the purchase to the service delivery, then we can move forward much faster.
Just as far as for the funders, there should be motivation from these solutions provided to show them that there's the economics needs to make sense to the funders, and I think with the right solutions, they can show economics that will benefit the insurance companies. And then I think there's a lot of talk in government and in the World Economic Forum about leapfrogging. We need to catch up and leapfrog to the developing markets. And there's three main principles that have been discussed, and one is new technology, two is change of mind state. So we need to change this mind state. Oh, that's too high tech. We need to innovate, as this is the topic of discussion, and three is better business practices. If we could conquer those three with the right solutions and the right motivation from government and also private sectors, PPPs, and various different aspects of the healthcare system, we can all come together and improve this healthcare system. And we're talking fast. So they want to leapfrog. So we need to start expediting this, because we need to start saving lives and providing healthcare and NHI, and to make it a reality, please God, one day. We need to, come together and work together, all parties. That's how I feel.
I'm very privileged to have, moderated this, and I think it's an exciting evolution of our healthcare system, and I think at the end of the day, what we're going to put in the center is the patient, who is the center of our universe. Thank you very much.
Thank you.
Good.